So my task today is to deliver some information about new antiretroviral therapy for pediatric and adolescent HIV. And this is a bit, like falling adult trend, but we are going to focus on what would be available for children and adolescents. And this could be new drugs and could be new strategies. So what are the trends? So I'm going to talk about the three scenarios: the newly infected patients, the naive patients, the ones that's failing, and finally the treatment simplification in someone who are virologically suppressed. So let me start with the new young boy, 16-year-old, and this is a real case. And he obviously an MSM, and just newly diagnosed by one of our outreach programs where we just went on and provide education and provide VCT, and if they are negative, we are going to provide them PrEP and PrEP education. And unfortunately, he was found to be HIV positive. He's actually a very busy boy, have a lot of school activities, and have a lot of hobbies, and he's, not have much time. He was shocked with the diagnosis, but he kind of know quite well about HIV. But what would be the best option for HIV-naive adolescent like this? So I'd like you to help me vote. I give you 4 choices, A, B, C, and D, okay? And in my talk, I'm going to use a lot of trade names because it's easier for me, okay? And you have to put up with my trade name things, okay? A is Tivia, B is Complila, 3 is Triumic, and Genvoya. Please vote, please. So let's see what you like. Money is not the barrier, okay? In this room, okay, pretending that the boy is so rich, he can reach out for any drugs he wants, okay? But I only give you 4 choices. All right, so majority are choosing Tivia. I'm telling you, the money is not the problem, okay? He's well-to-do, okay? Okay, and quite a few choose Triumic, okay? Oops, sorry. Okay. So I don't have the right answer for you, but you have to decide by yourself. But I'm giving you the information that you have to decide, okay? The first information I want to give you is the number of doses, proportion of the doses that you need to take in order to achieve viral suppression. In general, it's about 80-something%, I cannot read the number here, it's too small, more than 80%. But for integrase inhibitor regimen, it's about 75%. For NNRTI's regimen, is about almost 80%, 70-something. For protease inhibitors, you need like 80-something%, but for other regimens, you need 90-something%. So integrase inhibitors is the winner. And with this, it means that this is a regimen that gives you more forgiveness. It means that you can forget some doses without penalty, okay? And the second information, and this is a slide everybody have seen before, and this is a slide about the genetic barrier to resistance. And you can see that this, the x-axis tell you number of mutations you would need to make the drug ineffective, okay? And the y-axis tell you the potency of that drug. And you can see darunavir is, boosted darunavir is probably the best in terms of potency and genetic barriers. And dolutegravir and bictegravir are very much the same potency, but in a little bit lower genetic barrier, okay, but very high as well. Elritercavir and raltegravir has good potency, but a lot lower genetic barrier for resistance, okay? And NRTI as well as ripivirine in a much lower genetic barrier for resistance. And that's very, very important second information, okay? And when we look at the potency or efficacy, the potency translates to efficacy, and that answers well with a lot of clinical trials in adults. And as you can see in the summary of the studies in adults, you can see that integrase strand inhibitors regimen, particularly dolutegravir, is better. They are better than many of the protease inhibitors regimen, as well as efavirenz-based regimen. So all of the studies are in favor of integrase inhibitors. And the third information that you need is a single tablet regimen or multi-tablet regimen. And this is the information that everybody knows. You don't have to tell me I love single tablet, everybody loves it. But this is one of the very few studies that have shown that single tablet regimen is really facilitate virologic suppression. And this evidence is strong, and that the retention rate with the single tablet regimen is much higher than multiple tablet regimen, as well as virologic suppression. So, with the choice of single tablet regimen for the new drugs that will be available for children and adolescents, I put it in two classes. In NRTI, we have Tivia. This is not new, they are old. The second one is Complila, which is not getting into the country, but it's available outside. Odefsey is very much like Complila, but it's just using TAF instead of tenofovir. The rivaline is quite good, but it's now only approved for adults. It's new, okay? It's new in NRTI. So the second one is integrase strand inhibitor. The second group, this is dolutegravir has been, one of the most talked about drugs in this class. And dolutegravir, you have Triumec, and you have TLD. TLD just registered. It's going to be available in Thailand next month in a very low cost, so I'm very happy to hear that. Elvitegravir now is only Genvoya, which is a very attractive price. It's only about 2,500 baht per month, which is very good. And finally, Bictegravir. Bictegravir is now available for 25 kilos up. So when you're talking about adolescents, 25 kilos up is about, say, 10 years of age, you can use this, okay? 10 or 12, okay? For protease inhibitors, you are going to forget lopinavir and etazanavir. You will only think of darunavir, which is the current one, which is a single tablet regimen, is Simtuza, which is only available for those adolescents who are big, like more than 40 kilos. Okay, so in short, the captain said the new trend is for the newly infected adolescent children who are somewhat older, and this is a situation we found nowadays. We have very few new cases of newborns or infants. We have a large number of new cases naive in older children and adolescents. So the captain said it should be integrase inhibitors in single tablet regimen, and dolutegravir particularly has been prioritized because of the effectiveness, very good CD4 recovery, also effective against HIV too, has lower side effect, lower discontinuation rate, very effective against those who are resistant to NNRTI and as well as raltegravir resistant. It has higher potency, higher forgiving, higher genetic barrier. We talk about lower drug-drug interaction. And it's also working very well in pregnant and nursing women. Of course, in Thailand, we are not allowed breastfeeding, but in other settings, it transfers well to the fetus, and in the breast milk, it's once daily dosing and it's cheaper. Okay? And just recently, it was found that both dolutegravir in TAF formulation and in tenofovir, simple tenofovir formulation, both of them suppress the virus much quicker than the efavirenz-based regimen. The only problem, actually, I would say is good things, is that it increased the weight, more weight gain, particularly the arms that use TAF based with dolutegravir. But the increased weight gain, I would say is the improved well-being of the patient, but some people don't like to be chubby, okay? And perhaps get high risk of cardiovascular diseases for elderly or older adult people. Dolutegravir in children, how about that? We have the study 1093, which many of us in here are joining the study, and found that in children 12 years or up has the virologic efficacy very good, 80 to 83% for those young, less than 400 copies. And for children 6 to 12 years of age, they also have the data that the efficacy is about 80%, 78%. So these are not that as great, but because children are more difficult than adults, but they have CD4 gain quite good. So in short, overall, I think it looks good. Children is more difficult anyway compared to adults. And the only problem is that when this is an adolescent who is childbearing age, you might need to tell them about the neurotube defect if they become pregnant while receiving dolutegravir, which we know that the risk increased from 1 in 1,000 to 3 in 1,000. It doesn't mean it's contraindicated. It only means that you need to let them know the risk, okay? But the risk is greater than, the benefit is greater than the risk. So you can go ahead and give the drug to childbearing age women anyway, or adolescent anyway. So the WHO prioritized dolutegravir, particularly the 5 milligram and 10 milligrams, very soon will be available in mid-year of this year, okay? They also prioritized darunavir, and in the near future, they were talking about doravirine, okay? So the one thing that's excited to me is dolutegravir 3TC and abacavir in pediatric formulation STR, okay? Which will be available within this year as well, but I don't know whether it's coming to Thailand soon. Now, dolutegravir also has been developed in disposable tablet, which is very good. We use it already, and it's very nice. Children love it, parents love it, and they found a very good PK because the formulation, the disposable formulation, has 60 to 80% greater bioavailability and has been very well tolerated compared to the simple tablet. Okay, a little caveat for the folks who are going to be using dolutegravir, which is us, in the very near future. This will be the new trend. We have to be very familiar using dolutegravir in children and adolescents, but the dosing recommendation is totally screwed up. The EMA, the European and the US, recommend that from 15 to 40 kilos, you only use like 20, 25, 30 milligrams per day. But the WHO said, oh, you don't have to care about anything, just go ahead and use 50 milligrams. So what it means is that you can use anything. And whatever you use, you just pick the reference, okay? When you use 50 milligrams, you say, oh, I'm using according to the WHO. If you use 25, you just, oh, I'm choosing according to the to US FDA, whatever you want to use. Go ahead and use it, okay? So this boy, okay, was put on Triumeq, and he said the pill is so big. Triumeq is very good. Abacavir, we love it because we are young people. We don't have cardiovascular disease. We love abacavir. So Triumeq is dolutegravir, abacavir 3TC. But the pill is so big. What can we do? How can we offer? What can we offer? Please vote. You want to switch him to Tivir or Complila or Genvoya or Biktarvy? What are you going to choose? You have money, okay? You're not poor. You're very rich, okay? But let me tell you, they are not that expensive at all. They are very competing in terms of price, okay? Okay, now we're starting to have some people move more toward Genvoya, Complila, and Biktarvy, okay? Okay, let's look at the size. Let's look at the size. Let's look at the size, okay? You have Triumeq, which is the biggest in the size, okay? Triumeq here, total of 1,700 milligrams in one pill, okay? It doesn't matter how much you try, it's still big because the matter is so big, you know, the material is a lot, okay? But the smallest one is here is Genvoya in this scale, and even smaller than Genvoya is Biktarvy, okay? So Biktarvy, the brown thing, is very attractive to me, okay? Next is Genvoya, which is the green thing, okay? When you look at Biktarvy, the Biktarvy, the ones that just fed us for lunch today, you must remember that. Okay, it has a very good virologic suppression efficacy compared to dolutegravir. It has very similar side effects in terms of lipid, BMD, and renal, except for triglyceride that seems to be induce higher triglyceride level. And this is a study in adults. They conclude that Biktarvy have similar viral efficacy comparing to Triumeq, but it has better GI tolerance. There's no need for HLA checkup because they don't have abacavir in the pill. And it also can be used with the hepatitis B co-infection because it has TAF. So Biktarvy has been used in children, okay, in adolescent and children, 25 kilos and up. And the data up to 48 weeks found very good. The snapshot virologic suppression is great, CD4 is great, okay? Now let's go to the second small size, which is Genvoya. I like this one. Many of my patients have been using this, okay? Genvoya is elbitergovir, is not as good as bictegravir or dolutegravir in terms of genetic barriers. But I think for the naive people or someone who never failed, never have problem with resistance, the efficacy is quite great. And you can see that 92% viral suppression, that's the efficacy. And the renal as well as the bone are quite okay, okay? So what are the potential options for new case like this young man that I just read? There are another two options which is not available right now, but it will be the trend that will be available to use in the near future. The first other option is dolutegravir 3TC, the two-drug regimen. And the second one is darunavir cobicistat FTC-TAF, which is Symposium. So I give you a quick thing about the two-drug regimen DTG 3TC, okay? This is a study in adults that found that whatever you initiate, either with a two-drug regimen or three-drug regimen, you get the very similar outcome, okay? But the three-drug regimen gives you more side effects. What about Symposium? Symposium, which is darunavir, as I show you in the first scale, that darunavir is high in terms of efficacy and genetic barrier. And of course, when it comes into one single pill, in adult study, they found that the observed and intention to treat snapshot for virologic efficacy is quite good. It's up to 96%. Okay, so but these two drugs are not available for adolescent yet. Okay, for adult, only for adults. Okay, so the trend is there, but we have to think about what's the serious side effect right now, which people are pointing at, because neuropsychiatric problem is a very, very highly interested nowadays. If you want to apply for grants, do for this, you know. So 1 in 5 of Americans living with HIV have severe anxiety. And you know that people who are living with HIV and receiving efavirenz in children who receiving long-term efavirenz found that they have, have some effect on neuropsychiatric problems, okay? They feel uneasy more, and they have lower attention problems. They have lower attention in school. So people don't want to use efavirenz because of this. But what about dolutegravir? Would that affect the neuropsychiatric anything at all? Have any effect of that at all? In the phase 1 or 2 or even 3 trials, they have no problem with that, with the field, with very mild. But after the drug has been licensed and post-marketing surveillance, they found that they actually, dolutegravir have some neuropsychiatric side effects, but it's not that many, around 3 to 5% around that, okay? But it is true. Okay, let me move on to the second case, which is the second scenario. This is a young boy who has been receiving antiretroviral therapy for like 6 years, and he's been bored with it. Of course, the family is not that well, and he's been failing, and he's been receiving lopinavir, TDF, FTC after failing nevirapine-based therapy. And you can see all the red things in the resistance genotypes, okay? So what can we offer for someone who are failing, someone who is requiring the second-line regimen? So please vote. I give you either Triumeq or Genvoya or Biktarvy. So what you like? You have a lot of money. Don't worry about accessibility. Whatever you want to choose, you will get it. Okay, we have... Okay, most of us want to use Triumeq and Biktarvy. Okay, actually the second line regimen should be the least difficult to take, because people who need second line mean that they have difficulties with the first line, they have difficulties with taking the meds. So you need to facilitate them in, helping them in taking the meds. The thing which the least pill, the smallest pill, the once daily, or even, in the future, 1 injection per month would be the best, okay? So the integrase-based inhibitors-based regimen is probably the most attractive. So this is the study in adult that showed that dolutegravir versus lopinavir, dolutegravir is better in terms of second-line regimen, someone who failed the first line, okay, and has a lot lower side effects, adverse events. So that's why the WHO recommendation go for dolutegravir regimen for the second line, in adolescents and in children, except for the ones that start with dolutegravir and they fail, then you have to go for PI as the second line regimen. Okay, I move quickly on the third scenario. This is a 12-year-old girl who has been a good girl. She never failed, okay? But she's starting to complain, I don't want to take the drugs. But her virologic suppression is still there. So she now has been receiving GPO via Z250, and this is the real life. She has very good CD4 count, have viral load undetectable. She obviously said that, I don't want to take twice daily regimen. I think I deserve something better. So what's your choice? Vote, please. So you want to use TLD, which is coming to Sopasosha, universal coverage very soon, or you want to use Genvoya or Biktarvy or Juluca. You like Juluca? I like Juluca. So you can see what's inside here, okay? I think it sounds like, the Bipo, the jelly. Okay, lots of people go for TLD. Be careful, you have TDF and not TAF, okay? And many of you love Juluca just like me, huh? Okay, so sometimes you need switching. Someone who is so good, viral suppressed, And you want to change them, switch them to something else because of the three reasons. One is for toxicity, you want to avoid it, or you already have toxicity, you have to shift. Or second is for, easier life, simplification. And third is for the cost and sustain availability. And the choice needs to be considered of previous resistant pattern that the patient have before they come to this point, okay? So the dolutegravir-based regimen, you have three choices to choose. Is either Triumeq, which is TAF, TLD, or DTG 3TC, which is, I don't have the trade name now, or ripivirine plus NNRTI, this is not single tablet, or Juluca, nah? Or Genvoya or Biktarvy, or even just simply change TDF to TAF is already very good. There's a study in UK and Ireland in real life looking at dolutegravir in children and adolescents. Majority are the ones who are virologically suppressed and switch to dolutegravir. And they found very good virologic suppression, around 84%. And this is real world, so it's not as good as in under the clinical trials, but I think 80-something% is good enough. And they have very good CD4 count gain. What about the next one? When you look at dolutegravir, you would think a little bit about another thing which is also very good, which is Biktarvy. Biktarvy has very good, the PK levels compared to, in children compared to adults. So the single tablet regimen for someone in adolescents who are virologic suppressed can go for it. We don't have the data of Biktarvy right now in naive, but for someone who are virologic suppressed, it's good. And Genvoya is not bad at all. In tablet formulation, adult tablet formulation, we found very good PK, the PK parameters, much higher than adults. And all of those who are virologic suppressed who switch to Genvoya, which is the pill size is only a little bit bigger than Biktarvy, is quite attractive, and all of them has good viral suppression and tolerate very well. Okay. And we're proud to present this, Dr. Vanat Priya, under the Treat Asia sponsorship. We implemented another program. We switched efavirenz to ripivirine for someone who are virologically suppressed, adolescent, 25 kilos and up, 12 years of age and up. And we found that all the virologic suppression is quite good throughout 48 weeks of follow-up. And one good thing is you can see the blue bar here, the proportion of the blue bar here increase over the time. The blue bar are the score that show the better score of executive and cognitive function after switching. So after switching from efavirenz to ripivirine, these adolescents do better in terms of neurocognitive, okay? And what about Juluca? Juluca is quite good. It has good virologic success, particularly someone who needs to simplify the regimen. It has high treatment satisfaction with they can maintain the viral load throughout the week 100, which is very good. So I think Juluca, dolutegravir, ripivirine is very good if the price come down. And what about two drugs, dolutegravir 3TC? Either dolutegravir ripivirine or dolutegravir 3TC. We don't have the data of two drugs in adolescent, but it's coming soon. The data in adults is quite good, okay? What about exciting new drugs, okay? We proud to present the long-acting ones that people talk about it this morning, and the results is quite good. We are going to start doing the study in adolescents very soon. And what do we have for infants? Nothing much except for dolutegravir. So there'll be no space left for, I don't know. I keep talking. Okay, Okay, I don't know where we are. Okay, but I have passed. I'm sorry. Okay, this is the slide that I show the choices, okay? And this is the real life of dolutegravir in UK, okay? With 84% viral suppression. And this is the bictegravir PK data. So I go quickly, okay? And this is the Genvoya PK data, okay? And this is the ripivirine data. And this is the, after switching from efavirenz to ripivirine, but you keep 2 NRTIs, okay? You improve the executive and cognitive function. You can see the increase of the blue bars, okay? And this is the dolutegravir, ripivirine, Juluca, which has very good virologic suppressed. And this is dolutegravir 3TC, which are also very good. Both Juluca, both the dolutegravir, either combined with ripivirine or 3TC, both of them are good, okay? I'm sorry for, you can go back to review the slide. So what are the exciting new drugs? And this is the long-acting intramuscular cabotegravir ripivirine, which give the very good viral suppression, maintained very well. But we are going to have a clinical trial in adolescent in Thailand very soon, I hope. Okay, so this is the virologic suppression throughout the time of the injection, and people love it. What about the choice for infants? The infants, you don't have much to offer. Luckily, we don't have much of the new cases in infants. So it's still dolutegravir. But the new innovation is that they having disposable tablets. Granules not that good. And they are going to have VRZ01. So, but unfortunately, we cannot join the study. But I think VRZ01 will be too hard to reach. So we are looking forward to use just dolutegravir or lopinavir until they are able to use dolutegravir. So in terms of integrase strand inhibitors, anyone greater than 25 kilos, you go ahead and use whatever you want to use. You want to use dolutegravir, you want to use elvitegravir, Genvoya, or you want to use bictegravir. Either one of them, fine, over than 25 kilos. And dolutegravir, you can even use it after, anyone above 15 kilos. So there'll be no space left for lopinavir and isatravir, except for infants that may still need to use lopinavir for a while. What about the new strategy? The new strategy, this is very exciting for me, and I just talked to Annette that perhaps we should do something, the study like this, alternative day, 1 day off, 1 day on, and this is TVR in adults, and they found very much good efficacy, similar virologic failure, so very low, okay, so low virologic failure. So this is one of the strategy, which is very much the same as another study called the BITEC, and this one by the Penta group, and this one is the weekend of 5 days on, 2 days off, and found very good efficacy. The patients continue to have good viral suppression, but I don't know how many people have been using it because although the study come out and published, but not a lot of people in the clinic have been using this strategy. But I think we should explore more. I would be excited to see islatravir, which is like implanting very soon or once weekly dosing. So that would be very good for our adolescents. So thank you for your attention.